Okay, excuse me. The topic for this video is heart failure and the drugs used to treat heart failure. So I kind of want to start by just giving a little background on heart failure. Heart failure is one of our most common cardiovascular diseases, and even though treatment for other conditions that lead to heart failure, like for example hypertension, management of myocardial infarction, etc., these treatments have led to a decreased incidence, potentially, or an improvement in the development of heart failure. But still, once somebody is diagnosed with heart failure, 1 in 5 of those people have about a 50% chance of dying within 5 years. So the odds aren't great once the diagnosis is made. So for that reason, we're going to kind of focus on ideally explaining how this disease progresses, and in a perfect world, we would be able to intervene before the disease actually was diagnosed, or at least progressed to such an extent that it was irreversible. So heart failure is really, so let me back up for a second. Heart failure is essentially defined as the inability of the pump to meet the metabolic demands of the body. So as we know, the heart is a pump, and it pumps, the right side pumps into the pulmonary circuit, the left side pumps into the systemic circuit. And when the left side pumps, the blood that leaves the left ventricle is going to exit out through the aorta, and that blood then is going to travel to all our body tissues. And the cardiac output on average is about 5 liters of blood per minute pumped. So we essentially pump our entire blood volume every minute. So when the pump fails, we can't pump adequate blood to perfuse the tissues and oxygenate the tissues and deliver nutrients and remove waste. That's the function of the circulatory system, in conjunction with the heart as the pump, of course. So we do know that heart failure is accelerated by the conditions listed on the slide there, namely coronary artery disease, valvular disease, myocardial infarction, and diabetes. So currently there's no cure for heart failure, and therefore the goal of treatment should be to ideally prevent the development of heart failure, or slow the progression and or manage the symptoms. That would be the goal, and ideally leading to an improvement in the patient's quality of life. So I want to kind of talk a little bit about the pathophysiology of heart failure, because it can be pretty elaborate. So heart failure is used to describe a couple different types of dysfunction of the heart. And that dysfunction can affect the left side of the heart, it can affect the right side of the heart, or it can affect both sides of the heart. When the disease affects the left side of the heart, that's referred to as left-sided heart failure, and has traditionally been referred to as congestive heart failure. Although that congestive term sort of has been dropped, and now we just usually say heart failure. So the thing that characterizes left-sided heart failure is that the fluid that's not able to, the pump isn't pumping, essentially, and the left side of the heart is the issue. So the blood that's exiting the left ventricle is not, generally about 20% of the blood stays in, but 80% or so leaves, 75 to 80% leaves. So we have an increase in the volume of the blood in the heart that's not able to be expelled. So there's more fluid in the left ventricle than there should be, essentially. And so what's going to happen is that fluid ultimately, and in conjunction with that, the walls of the heart are going to become weakened as well. So as a result of that, the blood can't go out, so instead it starts backing up. So left-sided heart failure is really characterized by an accumulation of fluid in the lungs due to the backflow of blood into the pulmonary circuit from the weakened ventricle. All right, so that's probably the best way to characterize left-sided heart failure. This is the most common presentation of heart failure, and even though it starts on the left side, it oftentimes, or I should say almost always, is going to ultimately weaken the right side of the heart, causing the right side of the heart to fail as well. When the right side of the heart fails, then what's going to happen is the blood is ultimately so the same thing's going to happen, right? The blood is going to back up from the right ventricle into the right atria, and then it's going to result in systemic congestion, which means that the blood is essentially going to pool in the venous system, which will result in peripheral edema, so swelling, especially in dependent areas, and also ascites, which is when fluid kind of gets stuck in the abdominal cavity because of the portal circulatory system getting backed up. So left-sided heart failure can get, and often is subdivided into two different types. One is called systolic heart failure, and it's a result of resulting from diminished cardiac output and a decrease in the contractility of the myocardium. So the muscle is weaker. This is the most common type of heart failure. There's also a diastolic heart failure, and that occurs when the lungs are congested even though the cardiac output is fine. And most of the time, this is due to a restriction in the filling of the ventricle, leading to higher than normal pressure inside the ventricle. And what that pressure will ultimately do is create higher than normal pressure in the pulmonary capillaries, which then is going to result in pulmonary edema. So people can have either type of heart failure, and oftentimes they're going to have both. Heart failure can present quickly, kind of an acute presentation, or it can slowly progress over years. And that's probably the more common presentation, again, depending on what factors led up to this. Once there's a decrease in cardiac output, essentially what's going to happen is the tissues are going to be poorly perfused, because remember, that's where the oxygen and nutrients come from, right? The heart is the force behind this. So the tissues, when cardiac output goes down, the tissues are going to become poorly perfused, and organ failure is possible and probable if it continues. What we do know about the body is it's incredibly well adapted to compensate for heart failure. And a lot of this you probably learned in your physiology class, but we're going to talk about some of the compensatory mechanisms, because understanding the compensatory mechanisms is really helpful for understanding ultimately the treatment with drugs for this condition. So the first thing I want to talk about in terms of compensation is what happens with the ventricle itself. So when the left ventricle is forced to work harder because of an increase in preload or afterload, preload is the front loading of the blood, if you will, and afterload is the amount of pressure the heart has to generate to eject the blood. So either way, if the heart's having to work because of an increase in preload or afterload, or both in most cases, over time that ventricle is going to thicken and it's going to enlarge. And the term we use for that is ventricular hypertrophy. And the thickening and the enlarging is all about compensation. So basically the myocardial cells are going to change shape, size and shape. They're going to get bigger and kind of more beefy, more contractile proteins, etc., in an attempt to maintain contractility, so we can maintain essentially cardiac output, stroke volume, and cardiac output. So the term used to describe this structural change is cardiac remodeling. And this is good for a little bit, but the benefits start to kind of go down the other side after a while. So there's sort of a ceiling as to how much this compensation can help. If the work is still there, and so if the ventricle still has to continue to compensate for this increased preload or afterload or both, what ultimately will happen is those cardiac myocardial cells, the myocytes, will start to die off as in response to that increased workload, right? There's only so much they can do. So they'll start to die off in response to that increased workload, and fibrotic tissue will take over, right? Be laid down in their place, in the spaces in between those myocardial cells or those myocytes. And that, of course, is going to cause the myocardium or the ventricular wall to stiffen, and ultimately the contractility will decrease and the cardiac output will decrease. So you see how this starts off as a compensatory mechanism, but then ultimately is a detrimental effect of the heart. And that's going to sort of be the theme as we travel through these different compensatory mechanisms. Another is the activation of the sympathetic nervous system. So the fastest homeostatic response to a decrease in cardiac output is going to be that reflex stimulation of the heart via the sympathetic nervous system. So we know a little bit about the sympathetic nervous system by now, and what's going to happen with the sympathetic nervous system is going to release norepinephrine to stimulate those beta-1 receptors, which will ultimately cause the heart to beat faster, so increased heart rate, and also will cause the myocardium to contract with more force in order to try to get an increase in cardiac output. So that sounds okay, except for when you consider that the heart is failing, and you're making it work harder, right? This compensation is going to increase the work. The other thing the sympathetic nervous system is going to do is it's going to constrict arteries and also activate the renin-angiotensin-aldosterone system. So the higher angiotensin 2 levels, right? So the renin-angiotensin-aldosterone system, if you recall, I'm going to show you a picture in the next slide. Renin is released generally in response to either the sympathetic stimulation or decrease in blood pressure. And renin then will lead to the conversion of angiotensin 1 to angiotensin 2, which then is a potent vasoconstrictor. And you can see there angiotensin 2 is going to raise blood pressure and afterload because it's going to vasoconstrict like crazy, which is going to, of course, make the heart work even harder. And if somebody has, something like coronary artery disease, and that's how they got into this place to begin with, that can potentially make that quite a bit worse. The other thing that the renin-angiotensin-aldosterone system will do is it's going to cause, in addition to what we just talked about, it's going to cause a release of aldosterone. So the job of aldosterone in this capacity is to cause a retention of sodium and water, mostly at the distal tubules, which has a beneficial effect, of course, of increasing the fluid volume, so it's going to increase preload, and it's going to stretch the myocardial fibers, which would increase contractility in a normal situation. But again, there's a limit to this, and this heart is failing, so that may or may not be all that effective. And in the case of a failing heart or a diseased heart, this can ultimately lead to volume overload and pulmonary congestion, right? The other thing that research is showing actually that aldosterone, or I should say the activation of the renin-angiotensin-aldosterone system actually has even more detrimental effects. One of which is angiotensin 2 seems to promote ventricular hypertrophy, myocyte death, and fibrosis of the myocardium, stiffening of the myocardium. Aldosterone also acts directly on the myocardium, and it promotes fibrosis and stiffening of the ventricular wall too. So this is kind of new coming out, Originally we've been thinking, the renin-angiotensin-aldosterone system is great, in terms of compensation. But that doesn't necessarily seem to be the case. And we're going to talk in a little bit when we start to talk about the drugs, and we'll see that this is why the drugs, which are called ACE inhibitors, angiotensin converting enzyme inhibitors, have now become the preferred drug of choice for heart failure, because these drugs basically cut this renin-angiotensin-aldosterone system activation, and of course would decrease the risk of, or the propensity of, the ventricular hypertrophy, the myocyte death, and the fibrosis of the myocardium. Okay, lastly, the other thing I want to talk about are these other factors that can be released, ones of which are called natriuretic peptides, and there's a couple different varieties. There's the atrial natriuretic peptide released from the atria, there's the B-type natriuretic peptide released from the ventricle, and the C-type released from the brain. I'm just going to talk about the A and the B. So the ANP and BNP, to make it easier to say, those are both going. So the stimulus for the release of these factors is increased amount of blood in the heart itself. And when these factors are released, they are going to cause diuresis, which is an increase in urine output, right? So decrease in the fluid volume, vasodilation, and also decrease aldosterone secretion. So essentially these natriuretic factors kind of balance the effects of the sympathetic stimulation and the renin-angiotensin-aldosterone system. There's a kind of a new drug called Natricor, which is structurally similar to B and P, and is starting to show kind of a limited role in heart failure. in research, they've also identified a couple other potential mediators for the progression of heart failure, which I'm not going to talk too much about, but I want to just mention in case it piques your interest. One, or two of them are pro-inflammatory substances, tumor necrosis factor or TNF, and interleukins are found to be in high levels in patients with heart failure and are associated with a pretty poor prognosis. There's also something called endothelin, which is a vasoconstricting hormone that sometimes also found in the blood of people with heart failure, also associated with poor prognosis. And vasopressin, or antidiuretic hormone, is also elevated in heart failure patients, which causes, of course, fluid retention, and that doesn't seem to help too much either. So that's kind of the rundown on the pathophysiology of heart failure. It's pretty complex, but it's kind of important to sort of have a sense of what's happening, because the drugs that we're going to talk about are going to essentially try to kind of mitigate these compensations to a point to decrease the potential for left ventricular hypertrophy and myocyte death and fibrosis and ultimately pulmonary congestion and the failure of the right side of the heart. Okay, so in terms of symptoms, let's look at symptoms for a minute. I forgot I had this here. So here's a picture. I should have had this picture up as I was talking about that. So here's kind of just a schematic in terms of what we were just talking about. So you see up at the top here, we have our heart. Whoops, I went too fast. We have our failing heart. You can see the decrease in cardiac output. And then you can kind of see how it splits to how the body responds to that decrease in cardiac output. So we've got on the left side there of the screen, we have an increase in sympathetic activity, which then, of course, is going to cause sympathetic stimulation of the heart, which is going to increase the work ultimately, and can potentially lead to myocardial or ventricular hypertrophy. And then on the other side, you see what's happening with the kidneys as a result of the diminished renal flow, which is going to ultimately activate the renin-angiotensin-aldosterone system, causing vasoconstriction, which increases blood pressure, which increases work, causing sodium and water retention, which increases plasma volume, which increases preload, which is helpful, but except for it's failing, so it's not quite as helpful. And that can ultimately lead to essentially increased work, pulmonary congestion, etc. So it's a pretty complicated disease. And it follows a relatively predictable pathway once it starts going. The speed at which someone progresses is going to depend on a lot of factors, but you can more or less anticipate that once the diagnosis is made, that you're going to have to sort of manage all of these compensations. All right, here's the symptoms. So essentially, when someone develops symptoms, that means the compensations are off the table, right? The compensatory mechanisms have failed. So the main symptoms that someone's going to experience with heart failure is probably one of the first ones that will really be hard to ignore is shortness of breath, which you can see as dyspnea on exertion. And that will then progress to shortness of breath all of the time. They're going to be tired. They're going to, especially if this starts on the left side of the heart, which it most often does, they're going to experience pulmonary congestion, which would kind of look like a cough, and pressure when they lay flat. They can, as this progresses to the right side of the heart, they can develop peripheral edema, especially in dependent areas like ankles and feet. I mentioned the cough, and the orthopnea means having a hard time breathing when they're laying flat. So oftentimes they'll have to prop themselves up to breathe. And pulmonary edema kind of goes along with the pulmonary congestion. So the most common reasons why someone will suddenly decompensate and be symptomatic is due to fluid overload. Most of the time when they're not adhering to their plans, one of which is going to be sodium and water restriction, because they're going to have a hard time managing that, and or they're not taking their medications. So non-compliance to either the dietary recommendations or the pharmaceutical recommendations. All right. There's different stages for treating heart failure. You can see you're not responsible for memorizing them, but I kind of just want to run you through them because we're going to talk about the drugs next. So you can see we've got essentially 4 stages. There's different ways to look at this, but this is the one that seems to make the most sense. So we have at stage A people who are at a risk for developing heart failure. So at this point, they do not yet have heart failure. So this is where lifestyle modifications are going to come in, trying to figure out what's driving their potential towards heart failure. So treating those things like hypertension, high blood cholesterol, if that's a factor, diabetes. And of course, if they are hypertensive, then we'd probably want to get them on a drug. And one of the drugs for heart failure for hypertension that is also used for heart failure is that ACE inhibitor, which we're going to talk more about. It's currently the drug of choice. So once we progress to stage B, someone has some evidence of heart disease, like they've had a heart attack or there's some kind of valve disease, but they don't have symptoms of heart failure yet. So kind of we stick with what's going on with A, and then if you have not yet put in a drug, you'd probably put in a drug. And you can see we've got ACE inhibitors again. The ARBs are very similar to ACE inhibitors. We'll talk about those later. Beta blockers sometimes are added in here. Beta blockers are a little bit tricky because they decrease the contractility of the heart, but they also really decrease the work of the heart. So that's why they're added here. And so those seem to be added if someone has symptoms have prior symptoms of heart failure and they've had a history of a myocardial infarction or of a heart attack. And then as we progress to stage 3, there's structural evidence of heart disease. So that means they're having some remodeling probably, and they have symptoms like fatigue, fluid retention, pulmonary symptoms, etc. So now we're starting to add in some extra drugs. You see maybe another kind of drug for heart failure, which is where digoxin is, a cardiac glycoside, and we'll talk about it in a moment. Diuretics oftentimes are added in here, or some kind of maybe vasodilator. And then finally, in stage D, we have somebody who is very symptomatic, even at rest, which is not a good situation. That's showing that they're in decompensated heart failure. And so now we're probably going to have to think about even some additional drugs. So essentially, we've got like all the options down there, considering that they've already been doing an ACE inhibitor and or maybe a beta blocker. All right, so I'm going to stop this video in a minute and divide it so we can talk about the drug so it's not quite so long. So the goals of treatment for heart failure, again, so this is where kind of the drugs are going to plug in. The goals for treatment are going to rest on 3 real goals. One is to reduce preload. And I should back up to say really what it's all about is kind of decreasing the work of the heart without making it any weaker would be the ideal scenario. So reduce preload. Reduce the systemic vascular resistance, which would reduce afterload. Afterload, again, is the tension the heart has to generate in order to eject the blood. And inhibit the renin-angiotensin-aldosterone system, and also block the vasoconstrictor mechanisms of the sympathetic nervous system. So those are the goals of treatment. So we will come back and deal with the drugs in the next video.